The ovaries are talking, and trust us, you'll want to hear what they have to say. Science, tech, hormones, and a whole lot of honesty. This is Talking Ovaries. Hi, welcome to Talking Ovaries. This week, Tanya and I are talking about how the different provinces across Canada approach perimenopause and menopause care. What we would like to focus on is looking at some of the pathways or guidelines. Now, you might think this is actually quite a dry topic, but in actual fact, there's some really exciting and very interesting ideas and concepts that both Tanya and I have discovered whilst looking what happens across the rest of Canada. Excited about this, Tanya?
Yes, I am, because it is what we need, right? I think this is how we change things. This is how we help women until the medical system catches up and is able to look at midlife care and menopause care, perimenopause care as part of a whole system. It's not going to help us. So yes, I think we need to talk about this a lot. I think we need to push policy, the medical establishment, everybody to get caught up with the times so that we can help women feel better, so that we can live our best lives. Yes, I'm very excited.
Well, how this came about was I was invited to be part of a group of individuals who was developing a perimenopause and menopause pathway for primary care Alberta. In terms of what a pathway is or what guidelines can be, most of the province have two pathways. They have a clinical pathway, which is in general used by primary care or family physicians to provide guidance on what you do with a patient that has a particular condition. So, for example, there are urinary tract infection pathways, there are blood pressure pathways. So there are all kinds of pathways that provide guidance on when a family physician should be treating a patient and perhaps when they may want to refer them.
Is it like a decision tree kind of thing? That's how I kind of picture it, where you kind of say, does the patient have X, Y, Z, and yes, no, and you kind of go down a path of how to treat depending on what it is. Is that what
That's exactly what it is. That's exactly. Having said that, though, Tanya, they don't all use that model.
Okay.
That some of them are more sort of paragraphs of information and some of them use a pathway. And I think that was one of the things we were talking about earlier, is there doesn't seem to be a kind of consistent approach to perimenopause and menopause across Canada, even though we as women don't differ that much from one province to the other.
We need to know how we're tearing down the trade barriers across Canada. We need to tear down the trade barriers across the medical systems across Canada. Because it's silly, right? It's so silly.
It is. And some of these documents are huge. They're enormous pathways. One of the provinces actually has a pathway, like you say, like a flow chart. And then there's another 40 pages of notes for you to try and dive through to try and find the information that you're looking for. So it is actually really interesting to see how the different provinces approach it, and actually how some of the provinces don't have any form of pathway or guideline.
Now, I'm curious, when you were working on the pathway, who's involved in that process? Because I know you're not a doctor, so I'm excited that they had somebody who wasn't a doctor, just because in my general impression, I find the medical system to be very siloed, in the sense that they only want to talk to other doctors. And I find that it's not conducive to the best solutions necessarily. So who was in the room working on this?
Primary Care Alberta invited family physicians with an interest in midlife, perimenopause, and menopause care. They also had a number of specialists who work in a more of a hospital setting. There was one physician who worked in endocrine medicine, but particularly had an interest in perimenopause and menopause. And then there were two patient advisors. So I was one of the patient or non-medical advisors. It helped, though, that my background is that I'm a registered nurse and I've also worked in the pharmaceutical industry. So that really helped with understanding some of the information that was being put into the clinical pathway.
So there were no
Sorry, the
pharmacists, no
patient.
nurses, nobody like
No,
that.
no pharmacists. However, the process of creating this pathway was that we created this document and then Primary Care Alberta pushed it through to their pharmacy colleagues. So it was checked by a pharmacist, a dietitian,
Okay.
a psychiatrist, and one other group. I can't remember. I think it was to do with more preventative medicine. So it was a very much a team event. This was at times we were meeting weekly to go through the development of the pathway. Because remember, we were doing not only a clinical pathway, but we were doing a patient pathway as well. And trying to make sure that we followed Canadian guidelines as well as things that are specific to Alberta.
In my experience with managing teams and doing that kind of stuff, it would have been nice to have the pharmacists and some of the people who were reviewing downstream as part of the original discussion. It would capture more of what everybody sees and what they're experiencing, what women are coming to them with. But especially pharmacists, like I feel that pharmacists are really the first responders, I think, when it comes to perimenopause care, menopause care. And it would have been nice to have them at the table, I think. But anyway, that's just my little opinion.
Some of the highlights that I saw across the different provinces, there are some really gold nuggets that I found. And one of them was Saskatchewan. Saskatchewan, I'm going to have to read this, has a midlife health program for women that they've developed, which looks at, for various conditions, how you would start off at your family physician and then what the referral program would look like.
Okay.
The other thing that they have, the Mindfulness Menopause Project, where a group of women looked at the mood and psychological effects of menopause and perimenopause. They've actually come up with some clinical data and some guidelines. It was out of the University of Saskatchewan. So that was incredibly exciting to read that. The other thing that came out of my reading, aside from Alberta, because I was involved in that project, was BC. BC has a pretty decent menopause and perimenopause pathway. And obviously, some of us have heard the news that it looks like BC is actually going to be covering the costs of menopausal hormone therapy along with oral contraceptives. But again, their pathway wasn't a flow chart, it was more of a paragraphed document. So it's actually quite onerous to go through when I was reading through it.
Covering the cost is great. I mean, but now we're into this huge shortage, right? So there's a shortage of patches, there's a shortage of, because now women are finally agreeing or feeling more comfortable with HRT. And
Mhm,
of course, the producers of these products
mhm,
haven't been keeping up. So I am actually a little worried about whether industry will keep up with the demand for HRT, because it's not something that it's not a patented product. It's not something that makes a lot of money. And I do feel that at some point governments are going to have to step in and mandate that certain these types of medications are actually produced, that they keep some certain levels of production to meet the demand. I don't know how you handle that, but I feel there's a gap there that is going to catch up with us and is going to be detrimental at some point.
I think you raise a really good point in that, as far as women's health goes, it's okay for us to talk about these pathways and how different provinces handle perimenopause and menopause. But that's great as long as you have access to a family physician. I consider myself very fortunate to have the family physician that I have. He's very good. He really knows what he's doing. He keeps himself up to date. But there
You
are
know,
many
I
women out
love my
there.
doctor too.
Yeah,
Yeah.
there are many women out there who don't have access to
Yeah.
a family physician. So that's one of the first things.
Now,
The
but with
second,
that said, I go to a specialized clinic and I pay for my
hmm
doctor, right? I
hmm
don't get this care from my regular physician. And that's
hmm
not right either, right? I think women should have access. To me, this is primary care, right, for
yeah.
women.
And you do raise a really good point about access again to medication,
Yeah.
because the pharmaceutical companies, the product itself, so if we use, say, the estrogen patch, for
Yeah.
example, the estradiol 17 beta isn't patented.
Yeah.
That's not patented. It's the actual glue on the patch that
Mm.
is the part that they have ownership of. And so some women are finding that they are having to get patches substituted for a different brand. And sometimes they find that those patches actually stick a little better, and sometimes they don't. But to just reassure you that if you are getting an estradiol 17 beta patch, that it does contain the same product that you're used to. It's that glue, though, as long as the
Yeah.
glue is sticking. I actually had a conversation with my neighbor because she had a patch substituted for her last week, and she was asking me about it. And she said, "How do you know if you're absorbing the same amount?" And I said, "Well, when I take my patch off, the one I take off, I want it to hurt a little bit when I pull it off, like a band-aid, because
Yeah.
it shows me that it's sticking nicely."
Yeah.
So
Yeah.
we aside.
Yeah.
But yeah, I hear what you're saying. And some of these pathways, they don't really address some of these issues as well. The other thing that I found was quite interesting about some commonalities is the use of something called MQ6. So in 2000, and I think it was 17, Dr. Susan Goldstein out of Ontario released a paper called An Efficient Tool for the Primary Care Management of Menopause, and created a list of 6 key questions that either a patient can ask themselves or a family physician can ask the patient. And those questions are yes or no answers, and they include any changes to periods? Are you having any hot flashes? Are you having vaginal dryness, pain, or sexual concern? Are you having any bladder issues or incontinence? How is your sleep? So, new sleep disturbances. And finally, how is your mood? And that would be new or increased anxiety, irritability, depression, or low mood. The idea being that those 6 questions would then take the physician through a flow chart in
It's
how
that
to.
that would have missed me. I feel like those questions would have missed me. So yes, I had wonky periods, but I didn't have hot flashes. I didn't have vaginal dryness. I didn't have like my major symptom was joint pain and nausea. And I was going in and out of seeing my doctor about why are my joints so hurt so much. And like I went, I think, for 2 ultrasounds on my knees to try to see if there was something. And then I had nausea, so I actually had an ultrasound of my stomach and area to see if there was something that they could find, right? And I feel like that would mean like I feel there's so much more to cover than just that.
I hear what you're saying. There is some small print at the bottom of the MQ6 tool, which does actually say that in some populations, women experience new joint pains instead of or addition to vasomotor symptoms being hot flashes or night sweats. So they do try and cover all of that. And okay, I have to admit, when I first looked at this MQ6 tool, I thought, that really doesn't cover everything. But as you would move through perimenopause and menopause, you probably will find, to use your term, Tanya, you might get those wonky periods.
Uh,
I didn't really have hot flashes. I did have night sweats. I'm not sure about you. As for the vaginal dryness and pain, that really didn't bother me at all, or the bladder or incontinence issues.
yeah, I didn't have.
But sleep was an issue for me for sure. And I probably didn't recognize the mood changes, but as we've talked about on previous episodes, I didn't join the dots. I
No,
didn't.
no, exactly. And does it say anything about exhaustion? Because I didn't feel exhausted.
No, it doesn't. These are the key questions.
Mayo Clinic and Flow, and I will be transparent that I'm not a fan of Flow at all because of the whole issue they had with selling period data. I don't like to use their name, but since they co-wrote the report, I think I have to at least mention them. They had a study of 17,000 women between ages, well, 18 and over, it says, from December 2024 to May 2025. Most participants recognize hot flashes, sleep problems, and weight gain. So weight gain is not mentioned. To me, that was also something that I did notice, starting to put on weight in the midsection. That was, and I know a lot of women complain about that. Women aged 35 and over who reported being in perimenopause, their five most common symptoms were mental exhaustion, 95%, fatigue, 93%, irritability, 91%, sleep problems, 89%, and depressive mood, 88%. Right. So again, I'm not sure that there's a good match there with M6 without naming exhaustion, which is really their number one condition. But there's much lower scores from countries such as Nigeria, France, and parts of Latin America. And I can speak for Latin America because first of all, I'm half Argentine. I travel to Argentina often, and I've talked to a lot of my friends who are menopausal there. There's a completely different view of menopause. They don't talk about it as much. They're much further behind as far as understanding what the symptoms are and how to treat it. The report goes on to say that in these countries, such as Nigeria, South Africa, India, France, Ireland, and Latin America, digestive issues is their top symptom, which is really interesting because I don't hear a lot of people talking about that. And then they talk about mood symptoms such as depressive mood and anxiety was higher in other countries such as Germany, Spain, Venezuela, Netherlands, and India. So it's very, very interesting. The only reason I'm bringing this up because I think we just don't know enough yet, right? We kind of have an idea and we're starting to dive down what it is and what are the key symptoms and how it presents itself. But I think we're still learning, that there's so much more we need to do.
I would agree with you. And I think that if I was a family physician today and I had a midlife woman coming in to see me for her 10 or 15-minute
Go
appointment,
away. No, I don't have time for you.
I would feel pretty intimidated
Yes.
too, because it is a difficult area to work in because of the myriad of symptoms, there being differences across ethnicities. And then to top it all, there are different guidelines and different pathways that say slightly different things. And I think we then also have the complexity of having women who perhaps would come in who maybe 10 years ago who had a hysterectomy for whatever reason, and she's not had periods for a number of years. And what do you do with that individual? What do you do if you have a woman who comes in with breast cancer or who's had a clot risk in the past? However, I do think that we need to make the care of perimenopausal and menopausal women simpler, because then it becomes less daunting and less of, I hate to use this word, but less of an excuse
Yes. Yes.
to refer on and not treat, because this very much for the vast majority of women should be a primary care or family physician cared for area, and it doesn't need to be complicated.
No.
And I think something like MQ6 really can help us to simplify this and at least have a start, and that's what these pathways are there for.
Yeah. I did a report a while back where I had to do some research on what other countries are doing. And I really like the approach that Spain uses because
Mhm.
Spain actually has state owned menopause clinics. So I think there's 20 of them around the country. You don't need a referral to go to it. They are staffed by physicians, they have nutritionists, they have education, and women can just go to these clinics. You don't need a referral again, and you can actually be seen by a doctor and get assessed for your menopause care, and you can educate yourself. And I really think that that's a model that is needed because even if we were to get, for example, the code, right? Like I know in Ontario, as we were looking into, you need, a code that they can charge their time, that a physician can charge the time to for menopause,
Mhm.
but it's still broken down in these 15-minute discussions of one symptom at a time. Could you imagine for somebody who has multiple symptoms of menopause, having to book multiple sessions to go, well, today we're going to talk about my hot flashes. Tomorrow we're going to talk about my nausea. A month from now we're going to talk. You can't do it that way. Like you need to be able to have a discussion, have the time to be able to understand what's going on and what's the best approach and what physicians recommending versus what the patient may be comfortable with, right? Because some women are, give me HRT, and some women are like, I don't want to go near it. I'm afraid of it. And I know the UK is doing something similar. Like now they have your 45-minute midlife checkup. I mean, if you could do something like that, hallelujah.
Along with an £8 prescription. So that's all they pay. That's all women pay
Oh,
for the
yes.
menopausal
Oh, that
hormone
would be
therapy.
nice. That would be nice.
To bring it back to these pathways and some of
Yeah,
the
sorry, I was
differences
going
in
down a rabbit hole. That's what
no,
I
no,
do.
that's okay. We like your rabbit holes. I think that there's a couple of things to bear in mind, whether you're a physician watching this or whether you're a woman who is in midlife, is there is lots of information out there. Make sure that you are looking at evidence-based information. So I know, for example, the Alberta primary care pathway that I was involved in, they integrated MQ6. They used some of the Canadian Menopause Society, American, and the International Menopause Society guidelines as well. They looked at the Canada Food Program to add in some dietary information. So they really did try and pull in as much clinically based evidence as they possibly could. The downsides of these pathways that I've noticed is that they are not willing in some of these pathways to endorse specific products.
Do any of the pathways endorse specific? I don't think any of them do, right?
No, no,
No. But
no,
yeah,
none of them will endorse a specific product. Some of them will give you a list of what is available, but do remember that sometimes that can be out of date.
yeah.
The other thing to remember is, and we talk about this a lot, is really advocating for yourself. So getting data. We've talked about this before as well, is making sure that you're tracking your symptoms. There are tracking apps out there, the Canadian tracking app
Fast at rising.
yeah, yes, that we talk about fast step rising. You can use that one, but there are other
Use
methods of
whatever. We don't care. We just want you to track your symptoms. Write it on a piece of paper. It doesn't matter.
yeah,
Yeah.
that will really help you. And I actually brought this up as well when we were doing the Alberta primary care pathway. Do we mention anything about tracking symptoms? And in the patient pathway, they actually do. They make a recommendation to track your symptoms because it is helpful for your appointments. It is worth remembering that if you do get referred, there are not enough menopause specialists in Canada. And so, therefore, trying to stay within the primary care system if you can be really helpful because we have heard that sometimes if women don't join the dots, or in fact, family physicians don't join the dots, you end up being referred to multiple different
Yeah.
specialities
Yeah.
when realistically it's just perimenopause or menopause.
Was there anything common across all the pathways?
There were some commonalities in terms of when to refer. Those were the commonalities for the
Which
more
is like
complex.
always refer.
Kind of, yes. The other thing that was a big commonality that a lot of them addressed was lifestyle.
I feel that that lifestyle thing is like it's another excuse. Oh, you need to exercise more. Oh, you need to cut off this. It's always thrown back at women that it's always something they're doing. I was a very healthy, active person. There was nothing in my lifestyle, and it still hit me like a truck, right?
Well, if we were to just step back and look at clinical data, we know that for sure being overweight really affects your estrogen levels. We just know that the
Yeah,
data is there. So if you are, and we're not just talking a bit overweight, we're talking about some verging on obese in terms of the definitions. That's going to affect your estrogen levels. Also, things like smoking, that's going to affect how you deal with perimenopause and menopause. Alcohol is another one. So for me, when I hit perimenopause and into menopause, I quit drinking. I don't drink alcohol anymore. And I know that if I do have the occasional glass of wine, I feel really crappy afterwards. I also know that I developed certain food intolerances because of changes, as you talked about with digestion.
yeah. I don't
Um,
drink anymore either, by the way. I feel the same way. Alcohol just kills me. I don't drink anymore. I only
yeah,
do wet December, and that's it.
oh gosh.
But my alcohol consumption wasn't causing my menopause, right? And that's what I feel sometimes women are made to feel like that, right? That, oh, it's all these other things is not menopause. You still have to treat it. You still have to, you have to offer the HRT. You still have to address the issue. And then to add on to it, change your lifestyle, that's what I did, right? Like I got my HRT and then I just really realized that drinking alcohol, it doesn't do anything for me anymore. And I feel shitty the next day and I can't go for my run. And so I give it up and I feel fantastic. And, for other people's other things.
And I'm going to go on a little rant here. I have high blood pressure. I went to see a physician and she said to me, "Well, how much salt do you consume?" And I said, "Well, I don't add any to my food." "Well, you need to cut out salt altogether." So she went down this whole thing of the fact that my blood pressure was my fault. So I felt really, and I think the right phrase is gaslit. But I do think that addressing lifestyle as a topic needs to be talked about with perimenopausal and menopausal women because unfortunately, whether we like it or not, our bodies do change. However, there are things that you can do that you never used to do. So this whole idea of us not caring anymore about what people really
Yeah.
think about us and, feeling a lot more empowered. And I mean, hey, Tanya, look at us. We're
Yep.
on YouTube, we're all over the place, we're both in our 50s. And
We don't look at all. We don't care. I'm actually happy to be in my 50s.
there can be real upsides to this, but in terms of, let's get back to the pathways, if women are being told that what they're doing necessarily is contributing to it or causing it, that's wrong. I think that's a wrong perspective
Yeah.
on this. And that's not what the pathways were talking about. The pathways were talking about, okay, if you are going to start on menopausal hormone therapy or not, you should be addressing some of your lifestyle issues. But to be honest, if you're having intimacy or sexual issues because you've got a dry vagina, your lifestyle's not going to really affect
Yeah, going
that.
to counseling is not going to help that. I would be so gaslit by that. Like, are you serious? But
No,
I've heard that some women have been told that
they
they
have.
won't be given something until they go to counseling, and especially with mood symptoms, right? Like in menopause, that's huge.
Mhm, mhm. The other thing that all of these pathways did talk about was the use of Health Canada approved products. They do have a narrative on the compounded products as well. That is not something that's supported by these pathways. But if that is something that you choose to do that is right for you, then go
I
ahead.
take compounded estrogen and
Yeah.
and testosterone.
Do bear in mind that these pathways will refer to Health
Yeah.
Canada. To summarize this episode, Tanya and I always try and find three things that you can take home. The first couple of things is check out what it is that your province has. We will provide some links down below so you can check out what they do. The other thing is also checking out the MQ6 questionnaire. There's the actual paper that Dr. Goldstein produced, the questions, and there's also the algorithms. I know a lot of physicians really like this because it's just 6 questions. It may not be perfect, but hey, it's progress. If your province isn't doing a whole lot, then you can refer to other provinces. As we said, we don't all differ that much from province to province, so you can actually check out what the pathways are, but do bear in mind that prescribing can be a little bit different from one province to the other and what's available in one province to the other. And I think the final thing for me always is that advocacy piece, is tracking your symptoms regardless of what province you're in, or to be honest, what country you're in. Tracking your symptoms is going to help you to advocate for yourself so that when you're going in, if you're pretty desperate, like I was, couldn't think straight, couldn't remember anything, then I had a piece of paper that I was able to give my GP. And in actual fact, he kept a copy of that. And it's in my notes, and it's something we do talk about. And because mine was a paper one, he was then able to encourage his other patients to track their symptoms as well if they were coming in thinking that they were in perimenopause. So I think those are the top two that I came up with. Did you have one as well, Tanya?
Yeah, I mean, to me, it's more about trying to look at yourself and your ethnicity and try to advocate, because as we have seen, symptoms may not be within that chart. So if you are of a different ethnicity, track your symptoms and do a bit of digging into what might be happening in your country of origin, or talk to people. Again, track your symptoms, get some data, so that then you can go and advocate to your physician to say, listen, this is how menopause presents within my ethnic group, and here's some data. We need to start sharing our data so that we can put it all together, because we're just learning. We need to learn more so that then we can provide better care. Until we have more data, it's going to be hard to put these pathways together if we don't have all the information.
Well, thanks for joining us on Talking Ovaries. Thanks from Tanya and I, and we'll see you next time. Bye-bye for now.
Next time.
Talking Ovaries is here for information and empowerment, but not medical advice. We recommend discussing all aspects of your health with your healthcare provider. If you'd like to be part of Talking Ovaries, hit the like and subscribe button along with the notification bell. Or you can show us some love by writing us a review and sharing this episode with the people in your life. Talking Ovaries is written, created and produced by Tanya Lindsay and Judith Pringle. You can stay up to date with the Talking Ovaries by signing up for our newsletter and following us on Instagram, Facebook and LinkedIn. We read every review and email. This material is protected by copyright.